السلام عليكم ورحمة الله. أنا سعيد جدا أكون موجود في بلدي الحبيب العراق وفي مدينتي الحبيبة الموصل، وإن شاء الله تستفادون من هذا اللقاء بإذن الله. I'm going to talk about non-tuberculous mycobacteria. The title is NTM, but I'm going to speak about non-tuberculous mycobacteria pulmonary disease because NTM include other things like, for example, in HIV patients who have CD4 count less than 50, they can get disseminated mycobacteria, usually with MAC, Mycobacterium avium complex. You can have a skin disease like fish tank granuloma, that's mycobacterium as well. So I'm not covering any of those. You can have cervical lymph nodes in children, which is related to mycobacteria. So it's mainly non-tuberculous, and I will refer to this as NTM. So when I say NTM, it's non-tuberculous mycobacteria, and NTM pulmonary disease. If you read old literature, you will come across these titles, either atypical mycobacteria or environmental mycobacteria, opportunistic mycobacteria, or mycobacteria other than TB. And all of these are the same, synonymous to NTM, but nowadays it's far more widely used as NTM. Okay, so I'm going to cover briefly about the epidemiology of the NTM pulmonary disease, brief word about microbiology, risk factors predisposing to NTM pulmonary disease, clinical types of pulmonary disease, clinical presentation, and the significance of isolation of NTM from a respiratory specimen, and the diagnostic criteria and principle of the treatment is what I'm saying. Okay, so a little bit about epidemiology. So non-tuberculous mycobacteria is ubiquitous bacteria, so it means it's present in the environment, mainly in the soil and in the water. And NTM PD is acquired by inhalation or ingestion. Inhalation sounds reasonable, but ingestion doesn't sound very reasonable, but actually does happen quite a lot in people who have gastroesophageal reflux, who are in PPI, and especially those who go for surgery or they get this microaspiration of the mycobacteria. There is no person-to-person transmission, so it's not a notifiable disease. You don't need to isolate this patient. But only the exception of Mycobacterium abscessus, which is a major problem all over the world now, but particularly in UK in the cystic fibrosis patients. So cystic fibrosis patients who have Mycobacterium abscessus, they did whole genome testing and they found that this bacteria actually is transmitted from patient to patient through fomite, which is mainly being in the hospital setting using towels and the microfilm of the bacteria on sinks, on towels, and all of so it can happen, and it's very important to isolate those patients, not mix them together because it's easily transmissible, even if the sputum sample is negative. I mean, a direct sputum sample. So there is increasing incidence and prevalence of mycobacteria all over the world. Okay, so what are the reasons for increasing incidence and prevalence of NTM? The risk factors predisposing to NTM are increasing awareness of the clinicians about this condition, and also increasing access to the diagnostic method, refining diagnostic methods, and also obviously increasing use of HRCT. I'm just going to give you a quick example about increasing awareness of the clinician. We treat people who have what we call recurrent bronchial sepsis. Part of it is bronchiectasis. Before, we have been using macrolide, low-dose macrolide for those patients. And before we start the macrolide, we do certain things. One of them is try to look for NTM, because if you give a monotherapy with just azithromycin or clarithromycin, that NTM become resistant to antibiotic. So we have been looking for it, and the diagnosis of NTM have increased enormously in this group of patients. Obviously, some of it is contamination, some of it is colonization, but quite a few of it is genuine infection as well. Okay, so this is a very old slide of a pie chart in Tayside. In the Tayside, there is a population of less than 500,000, about 450,000 population. In 2 years, you can see here, there were only 18 isolates of non-tuberculous mycobacteria over 2 years period. So this was about 23, 24 years ago. I am pretty confident, I don't have figures, but I'm pretty confident that every single respiratory physician would see double or triple this number, particularly those who work on the infectious type of the subspecialty of pulmonary disease. Okay, so you can see the malmoense was #1 in Scotland, which used to be, but I think MAC is the one. MAC means Mycobacterium avium complex. They used to call it avium intracellulare. And you can see that in this slide, there was about 5 or 6% of fortuitum and Kansasii. So a little bit about microbiology. There are about 200 species of non-tuberculous mycobacteria. Yeah, you classify them based on the rapidity of the growth and also on the subculture, and also in the slow growing mycobacteria on pigment production. So the speed of growth, if they grow, let me just see that. So if this is called rapidly growing, RGM is rapidly growing mycobacteria. If they grow with less than so 6 days or less, and you slow growing mycobacteria if it takes 7 days or more. Obviously, it can take longer than that, and sometimes you have to. The standard incubation is for 8 weeks, but you have to extend it sometimes to 12 weeks in order to get the final result. The pigment production is the other way of classifying them in the slowly growing mycobacteria. So these are the ones that are in yellow are the common species that we see, at least in UK. So these are the common species that causes human disease. So among the rapidly growing mycobacteria, Mycobacterium abscessus, and as I said, this is mainly in CF patients, and because we have a dedicated CF doctors, I don't really have much experience with this, but it does happen in settings other than cystic fibrosis as well. But it's not as devastating as in cystic fibrosis, because once you diagnose that in cystic fibrosis, the outcome is not very good, and these patients are, as far as I know, up until now excluded from lung transplant. So this is one of the contraindications of lung transplant. So the slowly growing mycobacteria, they can be subclassified as photochromogenes, which produce pigment on exposure to light, like Mycobacterium Kansasii. Scotochromogenes is mainly in children and affecting the lymph nodes. Mycobacterium scrofulaceum, which is producing pigment when in darkness. Okay, so the first one is light, and so the second one in darkness, and the third one is not affected by the light. So non-chromogenes like avium complex, the MAC, I will refer to this. Remember, please, that this is called MAC, Mycobacterium avium complex, Mycobacterium xenopi, and Mycobacterium malmoense, among others. Okay, so what are the risk factors for NTM pulmonary disease? And please remember this when I'm explaining this, and a lot of this does exist in Iraq. So I'm pretty confident we have NTM disease in Iraq, but unfortunately may not be diagnosed as readily as should be. So old age, aging population, especially in the West, is a problem. And with age, you get a reduction in, you get the patient become more immunocompromised. The increasing exposure to NTM, for example, domestic environment in the houses, that people now have hot tubs, especially in America. They have the water work, that the plumbing the biofilm on the sinks, they all have NTM. Occupational, like, for example, people work in mining and farming. Recreational, those who have, for example, swimming pools, or they have showers or aerosols generating things. Major one, the main one that we're talking about today, is the pre-existing lung diseases. And these four, the first four, are the major ones. The COPD, especially those patients who have really bad COPD with some bunny formation, and bronchiectasis, CF, and previous pulmonary TB, but it can happen in other diseases like interstitial lung disease, independent of immunosuppression. So even if they don't have immunosuppression, they still can have NTM predisposed to it. Pneumoconiosis, which is the occupational lung disease, alpha-1 antitrypsin deficiency, lung cancer, primary serious dyskinesia, and other illnesses. There is this particular one the Americans are interested in. It's called Lady Windermere syndrome, which is a bronchiectasis that happen usually in the middle lobe and the lingula, or the lobe on the right side and the lingula. And these are in females who are not smokers, thin, middle-aged, elderly ladies, and thought not to have an underlying pulmonary disease, but in fact the CFTR, which is the regulator of the membrane cystic fibrosis, they have found that it does have subtle minor genetic mutations, and that's probably why they are predisposed to it. And also these patients usually have skeletal abnormalities like kyphoscoliosis or pigeon chest and mitral valve prolapse, among other things. Okay, so this is, for example, you can see there's a bronchiectasis here in middle lobe and in the lingula. Some of them not quite as signet ring appearance, but quite wide and a little bit of stream bud. And in these patients with we call it either Lady Windermere syndrome. It can happen in males as well, and it's not necessarily just in the middle and the lobe and lingula. It can happen in other lobes as well. And the other risk factors, obviously, is immunodeficiency. So it's not just, so you can have a primary, which is rare, like chronic granulomatous disease, for example. But these are rare, although they do increase the risk factor for NTM pulmonary disease. The acquired immunodeficiency, for example, in HIV, people who are diabetic, chronic kidney disease, malignancy, and alcohol, particularly this in the West, in association with severe COPD, predispose people to NTM infection. So things like medications like oral and even inhaled corticosteroid increases the risk for NTM infection. Immunosuppressive treatment, methotrexate, azathioprine, all the other treatments, and biologic agents like anti-TNF treatment, like there's plenty of them now, infliximab, for example, and cancer chemotherapy does produce immunosuppression. So what sort of type of NTM disease you would get? You would get either NTM pulmonary disease associated with pre-existing or structural pulmonary disease, the one that we mentioned, or you get an NTM pulmonary disease without an obvious pre-existing, like either the Lady Windermere syndrome, which is probably not strictly without underlying disease, or pulmonary disease, but you can also get, I mean, I have seen personally at least a couple of patients where they go to a surgery unrelated to the lung, and then they probably have microaspiration from their stomach, and they get no existing disease at all. But if you really look carefully, you will find that there is some sort of precipitating factor for it. And there is also this interesting hypersensitivity pneumonitis type picture related to NTM. So this is thought not to be related to direct infection, but rather the increased sensitivity to the NTM. And this is called for example, this you can see this CT scan that showed widespread ground glass appearance of hypersensitivity pneumonitis. This is the hot tub syndrome, which MAC aerosol in the hot tub they keep it inside the house, indoors, and it increases the exposure. Yeah. The clinical presentation obviously is very heterogeneous, depend on the underlying pulmonary disease. So you can have the symptoms of COPD or symptoms of bronchiectasis. But the key thing is the worsening. Oops, I keep pressing the wrong one. Worsening respiratory symptoms. So, for example, a person who have bronchiectasis, they produce sputum. You get infection every now and then, and all of a sudden that person is producing more sputum. You treat them, and they have poor response to the usual treatment. You have to think carefully whether there is another factor, and it could be an NTM infection. Systemic symptoms like fatigue, fever, loss of appetite, and loss of weight is very important in this group, and they may have hemoptysis as well. So if you are isolating an NTM from a respiratory symptom, what does that mean? It could mean contamination. So our lab, if it's Mycobacterium gordoni, for example, they say, well, this is likely to be contamination. Please repeat the culture, okay? So colonization, and colonization can be transient or long colonization, infection, genuine infection affecting invasive infection, or reinfection. So you have treated the patient, and then after a while they get the bacteria, which is reinfection. Sometimes it could be due to relapse, and only by doing genomic sequencing you'll be able to tell. So the diagnostic criteria for NTM, this is based on the ATS, American Thoracic Society, and British Thoracic Society, and European Thoracic Society guideline as well. They all agree on this. You have to have all of the following, not one or two. You have to have all of them. You have to have clinical symptoms like pulmonary and systemic symptoms, and radiologic, and the radiologic is either cavitary or fibrocavitary symptoms, signs, or nodular opacities, and this you can see them usually on chest X-ray. But obviously if you do the HRCT, so the radiologic appearance, either cavitary or nodular or fibrocavitary on chest X-ray. But obviously if you do the HRCT, you will see these, but you can also see bronchiectasis and small nodules, so-called nodular bronchiectasis. So you have to have this, you have to have this, and you have to have excluded other diagnoses, particularly TB, and this is particularly important in Iraq. And also infections like fungal infection, like Aspergillus. This is an X-ray. I don't know whether you can see there is a cavity here, just at the lower part of left upper lobe. This is a patient who had MAC infection, so it can give you a cavity very similar to TB. This is another thing which can be very similar to TB. They can just about make there is a cavity here. It's not very clear. There is some consolidation, and also maybe a bit of fibrosis. When you do a CT scan on this patient, you can see there is a cavity. If you look carefully, this patient has bullous emphysema, and there's a bit of scarring. This patient had Mycobacterium kinsaceae. Kinsaceae produces cavities more than the other, and MAC can produce cavities as well, but MAC can also produce bronchiectasis. So it's not specific, but it makes you suspect that this may be. And this is one of the strains that you can actually cure in the majority of patients, Mycobacterium kinsaceae. Okay, so this is another example of, you can see here, there is tree in bud. This is more classical tree in bud appearance, and there are some enlarged airways with the signet ring appearance and some changes here. Usually it's multi-lobar. This is Mycobacterium avium complex disease in association with bronchiectasis. Okay, so in addition to what I just said, so the clinical, the radiological, you exclude the other diseases, you must have one of these. So you either have a positive culture of at least 2 separate samples of expectorated sputum. If not diagnostic and you suspect it, keep repeating the samples. The second, or either this, or you have a positive culture from at least 1, in this case, not 2, bronchial wash or bronchoalveolar lavage. Or you have a transbronchial biopsy or other lung biopsy with mycobacteria histologic features like granulomatous appearance, and also seeing the acid-fast bacilli, and one or more, plus a positive culture. So that the material that you take it from the biopsy, you see histological appearance in it, and you have to culture positive. Culture is very important here. If you don't do that, then you have to have biopsy, same as above, but you have to have at least here one sputum or one bronchial washing positive culture as well. Okay, so now you have diagnosed this as patient with this criteria. What do you do? In a patient who meet the diagnostic criteria for NTM pulmonary disease, initiation of treatment rather than watchful waiting is the generally recommended. But there is a big but, which is it does not always necessitate the initiation of therapy, as this is based on balancing the benefit and the risk for that particular individual. So you wait by person, patient by patient. Okay, so this is some of the factors. Yeah, some of the factors, for example, if the patient is clinically unwell versus mild symptoms, this push you to treat. Low body mass index, losing weight, important factor. More virulent strains, low albumin, cavitary disease in particular, rather than bronchiectasis, and underlying immune suppression and persistent sputum positivity on AFB. So this tells you there's likely to be mild symptoms, medication intolerance if a patient is intolerant. If they have just bronchiectasis and really they are not too bad, they're not losing weight, you can watch and wait and watch. So you can see these factors depend on the bacteria, and it depends on the host, on the patient. Then the bacteria, for example, if you see Kansasii, you have a 95% chance of culture conversion. But if you see, for example, abscessus or xenopy, there's less likely chance of that. So I would treat patients with Kansasii if at all possible. After the 95% conversion, about 15% relapse, so you end up with 80% chance of cure from the disease. Okay, so these are just some important general. I must cover this, I think, within the next couple of minutes. So the management, you have to have a management of coexisting lung disease. You have to optimize it before you are actually ascribing the clinical decline of the patient to just NTM pulmonary disease. For example, somebody who have bronchiectasis and you're not doing sputum clearance, exercise, they're not drinking enough water, they are not treating it promptly with antibiotics with sufficient period of time with high dose, then you're not really, we don't really know whether this is bronchiectasis or the NTM added on it. So you need to do that first. And in vitro susceptibility does not always correlate with the response to the treatment, except for those patients, for those antibiotics that are associated with a treatment failure. For example, if you have Kansasii, you must check for rifampicin, because resistance to rifampicin is associated with treatment failure. If you have Mycobacterium avium complex, you must have clarithromycin or macrolide resistance, as well as amikacin resistance, because they are associated with treatment failure. If you have the abscessus, then you need a battery to guide your treatment, but not to dictate your treatment, which means that it's not mandatory that you choose these antibiotics. I'm just going to go back there. So the other thing that is, I'm sure Nick was part of the team of treating difficult chest infections, so difficult pulmonary infections, and one of them can be Mycobacteria. So you get a respiratory physician, you get an infectious disease physician, you get a pharmacist sitting, and a dietitian, and also a physiotherapist for sputum clearance and advising on pulmonary rehabilitation. So you need to optimize the whole patient, not just for the sake of treatment. And combination antibiotics, the treatment should continue for a minimum of 12 months after the culture conversion. Shall I continue for a little minute? Yeah. Right. Okay. So so I'm not going to go through this because they are all in the guideline. but you can see if, for example, Tinsacea, you have rifampicin, ethambutol, either isoniazid or azithromycin. If it is rifampicin sensitive, resistant, then you go to quadruple add things like moxifloxacin in addition. But these are all written, so they are. I don't really need to. One word about what do you mean by culture conversion? If the patient, for example, you treat a patient for 3 months, and after 3 months you culture and the culture is negative. What do you do now? You wait 3 months and you do 2 more samples. So a total of 3 samples. If they're all negative, this is defined as culture conversion. After that, you continue for 12 months treatment minimum for all of the mycobacteria. Okay, and recurrence means that you have 2 positive mycobacterial samples after the culture conversion, and refractory disease, you treat them for a whole year and they're still showing culture positive. That means a treatment failure. Okay, so yeah, this is just last 2 pictures. The first one is actually, yeah, so this is a patient with bronchiectasis seen by one of my colleagues. This is before the guidelines were available, long time ago. And MAC was isolated from sputum, but just 1 sample. He was started on quadruple therapy at that time because we did not have the clear guideline. So patient has side effect, stopped the treatment, remained well, and then after a while started getting recurrent exacerbation of bronchiectasis. But just by optimizing the treatment of bronchiectasis, and then repeated culture negative, which means this was probably just a colonization or contamination. So put them on low-dose macrolide, patients very well. So I think that quadruple therapy was treating the bronchiectasis with the azithromycin that he had. So remember, when you have bronchiectasis, you have you can't wait unless it's progressing, causing damage. This is the last last slide. So this is a patient who presented with a single solitary pulmonary nodule, chest X-ray, solitary pulmonary CT scan. He went for a CT-guided biopsy. It's not diagnostic. Possibly some granuloma, but we can't be certain. So what happened? He went for a PET scan, and the PET scan was positive. So what do? PET scan positive, the high FDG avid scan. It could be TB, it could be mycobacteria, or it could be cancer. So infection can produce the same thing. This patient, after discussion with the patient said, I have to have this removed. So he went for that, Mycobacterium avium complex. So remember, single nodules in the lung can be due to NTM. Thank you very much.